Good afternoon. My name is Carol Tan and I'm a thoracic surgeon at St George's Hospital in London. First of all, I'd like to thank the organisers of the masterclass for inviting me to talk to you about N2 disease and the management of N2 disease in non-small cell lung cancer. You've already had the talk by Mr. Shah about lung cancer, and he's touched upon nodal disease, nodal classification in lung cancer being important. This is something you've already seen. And in lung cancer, we use the anatomical position of lymph nodes to classify it rather than the number of lymph nodes as some other tumor sites might do. So we're focusing for this talk on N2. So that is where there is metastasis in the ipsilateral, mediastinal, or subcarinal lymph nodes. You've also already seen this. This is the nodal map that has been proposed to unify two different previously used nodal maps, the Naruki map used by the Japanese and the Mountain-Dressler modified ATS map. And this divides the lymph nodes into 14 stations. So the mediastinal lymph nodes are from 1 to 9, and the hilar nodes are from 10 to 14. They've also proposed classifying nodes into different zones to aid further analysis of prognosis for the future. So this is the Tnm staging, again from the 8th edition. And we do know that patients N0, N1, it's reasonably straightforward. They do have a surgical option. Patients with N3 and above who are in stage 3B and above probably don't have any surgical option. And those in the N2 classification where there are stage 3A or 3B disease, that's a bit more controversial. We do know that nodal status is probably the most reliable indicator of prognosis. You've already seen this survival curve. So if you have no lymph node involvement, you have a 5-year survival of 60%. And if you've got N3, it drops dramatically to 9%. Within each T category, you can also see that there is the difference in the survival curve from N0 to N3, certainly in T1 and T2. But when you go to T3 and T4 tumors, there's less difference between the N0 and N1 status. The 5-year survival, and these are for patients who've been clinically staged, T1, N2 gives you a 5-year survival of 34%, T4, N2 drops to 9%. When you look at patients who've had resection, so the PN categories, the 5-year survival is a little bit better. T1, N2 has a 5-year survival of 50%, T4, N2, 24%. Whether or not you have a complete resection, so it's R0 or all other R status, you will see that the N status will reflect prognosis. You've already seen this subclassification. So we talked a little bit about the anatomical position determining whether you're N0, N1, or N2. The reason why they've looked at whether or not you have single station or multi-station nodal disease is because we're really looking at whether the volume of disease in the lymph node also has an effect on prognosis. So just to recap, N1A is a single station hilar lymph node. N1B is multiple hilar lymph nodes. N2A is a single mediastinal lymph node, ipsilateral, and N2B is multiple mediastinal lymph nodes. And if you look at the survival curve for N1B, so multiple hilar lymph nodes and single N2, the survival curves overlap. So they're very similar. If you then look at the skip metastasis, So a single N2 with no hilar lymph node involvement and single N2 with hilar lymph node, there's also a difference in the survival curve. The survival curve, the prognosis for P2A and P2A1 was very close to that of N1B. So what does it tell us? It tells us that the N2 disease is actually quite a heterogeneous group. You can have single zone or single station or multi-zone, multi-stations. The lymph node size probably makes a difference in terms of prognosis. So whether they're bulky or not bulky, or whether they're occult. Occult meaning that you might have a cancer diagnosed in the left upper lobe here with a normal looking lymph node in the subcarinal region with no PET avidity, but during the operation, post-operatively, you find that there is actually disease in the mediastinal lymph nodes. Then you can also talk about whether the lymph nodes are fixed or non-fixed, and we'll talk a little bit about that a bit later. So the reason we are addressing it is because it has an impact on treatment options and probably prognosis. So what are the current accepted treatment options for N2 disease? If you've got a fit patient with the appropriate physiological reserve, you probably want to be considering bi or trimodality therapy. Because most of these patients are stage 3A or 3B, you're looking at systemic therapy for distant control. So you're thinking about some form of chemotherapy. And you're also going to have to think about the local therapy for local control. And this may be in the form of surgery or radiotherapy. So what about the evidence then? Well, I'm only presenting to you randomized controlled studies I have found. These two address chemotherapy and surgery versus chemoradiotherapy. And they were published more than 10 years ago now. And they looked at stage 3A disease. The ERTC study looked at stage 3A with proven mediastinal lymph node PN2 disease. All patients underwent 3 cycles of induction chemotherapy. If they responded, then they were randomized to either surgery or radiotherapy. And they managed to randomize 332 patients. However, they found that the median survival was very similar, as was the 5-year overall survival. The second study was done even earlier, published in 2002, also in proven mediastinal N2 disease. They also gave chemotherapy but 2 cycles, and if the patient remained stable, they randomized to surgery versus radiotherapy. They targeted 224 patients, but surgical trials are incredibly difficult to recruit to, and they managed to recruit only 73 patients, so they closed early. What about chemo, radiotherapy, and surgery, so trimodality versus chemoradiotherapy? This is actually a landmark study published in 2009, the Intergroup 0139. It was a multi-center phase 3 randomized controlled study, also looking at the same patient group. And they gave 2 cycles of induction chemotherapy and induction radiotherapy. If the patients remained stable, they were then randomized to have surgery or to complete further radiotherapy up to 61 grays. They then received consolidation chemotherapy of further 2 cycles. And out of their target 612 patients, they randomized 396 patients with approximately about 200 patients in each arm. All patients had to be deemed resectable at the outset. And in 76% of the population, they had only a single station N2. So what was the result? Well, the overall survival for the surgery versus radiotherapy group was very similar, 23.6 median survival for surgery versus 22 for the non-surgical group. However, when they looked at progression-free survival, there was an improved outcome with surgery, so median progression-free survival of 12.8 months versus 10.5 months in the non-surgical group. 5-year survival, 22.4 for surgery, 11.1 for non-surgery. If we looked a little bit further in the surgical arm, 155 resections took place. There were 3 wedge resections, of which there were no deaths, 98 lobectomies, and there was 1 death, and a third of the patients, 54 patients, underwent pneumonectomies. And in this group, the mortality was 26%. So this had an impact on the survival curve, if you like. If you look here, this is the surgical arm, and it dropped off quite quickly at the beginning. So a post hoc analysis was performed, looking at the pneumonectomy group as well as the lobectomy group. They matched 90 patients who underwent lobectomy with a similar cohort who underwent chemoradiotherapy, and found that in this post-hoc analysis, the median overall survival was much better, 33.6 months for the surgical group, and only 21.7 for the non-surgical group. When you looked at pneumonectomy, this was not the case. Moving on further, if we look at chemotherapy with surgery versus chemoradiotherapy and surgery, there were 2 studies done as randomized controlled trials. Unfortunately, both of them failed to show any difference in terms of a better treatment option. One of them, again, closed early. So you saw earlier on that there was a meta-analysis done by McElnay, which included Mr. Lim, Professor Lim, and this was the one published in 2015. There are other meta-analyses that have been published. The majority have shown that there is no advantage with one treatment versus another, but the groups which included surgery did seem to have a better outcome. Before we go on, we need to talk about what is actually resectable N2 disease, because I've already shown you earlier on that N2 disease is quite heterogeneous. And in actual fact, there is no universally accepted guidelines. There's no consensus for a definition of resectable N2 disease. And you know that N2 disease has got all these different possibilities, which we probably should be considering when, as surgeons, if you're sitting in the an MDT, these are the things that may be going through your mind, whether it's single zone and station or multi-zone and station, whether the size of the lymph nodes might have an effect on how you might approach the patient, whether it's bulky or non-bulky, whether it's fixed or non-fixed, whether the patient has had some form of neoadjuvant treatment and has already responded to it, whether you might be able to perform a lobectomy or whether you require a pneumonectomy to remove it. And at the end of it, you also need to make sure that you've got a patient who is fit enough to undergo the surgery that you're proposing. We talked a little bit earlier on about a complete resection. So I think it would be very reasonable to say that the cancer is resectable if the patient is able to achieve complete resection. So the small occult, single lymph node, single zone, non-fixed lobectomy is going to be possible. Also, the patient who's responded to induction therapy is probably much more resectable than and patients in this group, whether it's large, bulky, multiple, fixed, requires pneumonectomy, and it's persistent after induction therapy. So what about fixed and non-fixed? What does this actually mean? Can we actually tell on the radiology? Because it's really, you define something that you encounter when you're actually operating, fixed or non-fixed. You can't really say that something might be fixed on radiology, can you? Or can you not? Well, if you've got discrete nodes that can be distinguished, does that mean that this is less likely to be non-fixed? And if it's free from major mediastinal structures, including great vessels and trachea, does this mean that it is non-fixed? This is a PET scan of somebody with a 2R lymph node, which is positive. as well as the right upper lobe cancer. And this looks a reasonable size, probably about 2 centimeters. And you might say, well, it's probably going to be non-fixed. What about on CT scan? So on the left side, this is the pretracheal lymph nodes. So you can see 2 discrete lymph nodes, which are enlarged. But going down to the subcarinal region, they become a lot bulkier. They do seem to be distorting the right main pulmonary artery, and they do seem to be distorting the right main bronchus as well. So that probably, you might say, is probably more likely to be fixed. So looking at guidelines then, in terms of how we approach it, well, the Bts Guidelines, this is published in 2010. We're still awaiting a revision of it, but they did make a statement about N2 disease, and they said they differentiated it between bulky and fixed and non-fixed and non-bulky. So patients who have got bulky and fixed N2 disease for T1 to 4 with no metastatic disease, you should be considering radical radiotherapy or chemoradiotherapy. For those with non-fixed, non-bulky single node disease, then you could consider surgery, but as part of multimodality treatment. This is the American College of Chest Physician Guidelines, published in 2013. They also looked at N2 disease, and they defined these 3 different subgroups: the infiltrative stage 3, so N2 or N3 tumors, the occult N2, which we talked about, so the ones that you find intraoperatively, or the ones where you are discrete and clinically evident on PET and CT scan. So infiltrative, what they say is that nodes can no longer be clearly distinguished or measured. If you've got discrete, then the individual nodes can be distinguished. They could be large or they could be normal size. They avoided the terms of resectable and unresectable, as they think that these definitions are impossible. The terms are subjective, and they may depend on an individual surgeon judgment on that day. And they could also vary from day to day. So for patients with infiltrative N2 disease, they have suggested that combination chemotherapy and radiotherapy are recommended. Neoadjuvant induction treatment followed by surgery is not recommended. For patients with discrete N2 disease, so the ones that you find on CT or PET scan, you would consider either definitive chemoradiotherapy or induction therapy followed by surgery over surgery or radiation alone. So they're recommending combination treatment. What they also say is that primary surgical resection followed by adjuvant therapy is not recommended, except if it's part of a clinical trial. For patients who have occult or incidental N2 disease found at the time of surgical resection, and they have suggested that you should complete planned surgical resection with mediastinal lymphadenectomy. And then the patient should then go on to have adjuvant platinum-based chemotherapy. Sequential adjuvant radiotherapy is suggested when concern for local recurrence is high. And I'll touch upon this again a little bit later on. There are also European guidelines. They also differentiate the N2 disease into incidental, potentially resectable, and for this group of patients, they say it's minimal N2 or single station at staging. They've got another group here where it is potentially resectable N2, but there's a risk of incomplete resection. So, for example, the Pancoast tumors subsets. And then the bulky or multi-level N2 at staging, they've classified as unresectable N2. This comes from the European guidelines as well, and it's quite a nice algorithm in terms of what they suggest should be done. So if you've got no enlarged lymph nodes, peripheral tumor, you don't really need any invasive lymph node sampling, EBUS or mediastinoscopy. But if you proceed to surgery and you have unforeseen N2, you complete the surgery and you give adjuvant chemotherapy, and in brackets, radiotherapy. If you have no enlarged N2 but a central tumor or hilar lymph nodes with enlarged discrete N2 disease, you stage with EBUS or mediastinoscopy, and depending on the stage, you would consider surgery for N0 to N1. For N2, which are potentially resectable, you go on to treat with multimodality treatment. For N3 disease, these are obviously non-surgical multimodality treatment. So just to summarize again, intraoperative documentation of N2 surgery followed by adjuvant chemotherapy. Single station preoperative N2, PN2 demonstrated. They've suggested that you can proceed with resection followed by adjuvant chemotherapy, induction chemotherapy followed by surgery, or induction chemoradiotherapy followed by surgery. For multi-station N2, concurrent definitive chemoradiotherapy is preferred. So post-op radiotherapy for N2 disease. There's a question mark in the brackets in the previous slide because that question wasn't answered until now. This was a randomized study presented last year at the ESMO Virtual Congress, where they randomized 501 patients who were found to have N2 disease postoperatively to either having postoperative radiotherapy or no postoperative radiotherapy. And they found that actually there was no survival advantage for those who underwent radiotherapy. So it's no longer being advised routinely for N2 disease. I'm going to end with one last study for you. This is the Pacific trial. This would be something that oncology doctors will be very excited about because it looked at immunotherapy in stage 3 non-small lung cancer. And it was a randomized study which was multi-center. Patients underwent 2 cycles of chemotherapy concurrently with radiotherapy. And if there was no progression, they were then randomized in a 2-to-1 ratio to receive immunotherapy, durvalumab, or placebo every 2 weeks for up to 12 months. They found that the patients who had immunotherapy had a median progression-free survival of 16.8 months versus those who didn't have immunotherapy of 5.6. So this is an 11-month difference, which is quite significant in oncological studies. The survival advantage was also persisted to 18 months here. This is the survival curve, so durvalumab being a little bit better or significantly better than the placebo group. This study led to an editorial in the same journal where an oncologist stated that the data from this study may end the debate about the role of surgery in patients with stage 3 non-small cell lung cancer, with durvalumab and chemoradiotherapy redefining best practice for all patients with stage 3 non-small cell lung cancer. Now, what I didn't tell you was that this study was only done in unresectable stage 3 non-small cell lung cancer, not the resectable ones. So we need to be a little bit cautious about oncologists claiming that there's no role for surgery in this group of patients, because we know that stage 3A non-small cell lung cancer is a heterogeneous group, and some patients will benefit from surgical resection within multimodality treatment. There are many other studies now in stage 3 non-small cell lung cancer looking at adjuvant immunotherapy. So until then, I think we should actively be participating in MDTs and making sure that potentially resectable stage 3A N2 disease is not denied surgical treatment. So in summary, stage 3 N2 disease, non-small cell lung cancer, represents potentially a curable disease, although the prognosis remains poor. Remember that N2 disease is heterogeneous. The optimal treatment is still controversial, but it involves multimodality treatment. And surgery should form part of multimodality treatment for those we deem to be resectable, although there is still a lack of universal agreed definition for resectability. And we need to look to clinical trials to give us more information on how to manage this patient in the future. Thank you very much.